So now we're going to move to the next session. And here I'm absolutely very, very grateful to Peter Lloyd-Sherlock for organizing it and for bringing together Veronica Montes de Oca, Gabrielle Kelly, and Mônica Frank, with experiences from Mexico, South Africa, and Brazil. And the panel is on local government strategies to address COVID-19 in long-term care facilities, Mexico, Brazil, and South Africa. So thank you very much, all of you, and Peter in particular, and all yours. Thank you.
Hello, everybody, and I hope you're able to keep up with an incredibly amazing but extremely intense event. It's fantastic it's being recorded because I think we're all going to have to listen back to quite a lot of this to make the most of it. We're going to present some initial work from an ongoing study of COVID and long-term care facilities in 3 different countries. And at the center of this project is really trying to work closely with local government agencies to compare what they've been doing to try to support facilities, assess the effects of those actions, share useful ideas, and try and learn some lessons. Our starting point for this is, hang on a minute, how do I get the slideshow to play? I've got so many boxes on the screen at the moment. Oh yeah, there we go. Yeah, here we are. The starting point for this is an emergency policy framework that we quickly put together early on in the pandemic to try to guide local government agencies with a particular focus on low and middle income country settings to respond to the pandemic. And we call this the SEAT framework. It's basically an acronym based on 4 core elements of that strategy. And we have a related document that we update every now and again, and you can access it via this link. And in fact, when I exit share screen, I will also send it through the chat box. So today we're going to mainly focus on just one part of this framework because we don't have very long. And that is the first part of it, trying to improve coordinated responses between local government agencies working in the same place. So often, as you know, different government agencies in the same location have got different kinds of responsibilities for long-term care facilities. We've already produced a number of outputs and papers, and you should be able to access most of them on this platform, the global platform on older people and coronavirus in low and middle income countries. And I've just put up some examples of some of the many blogs and activities that we run there. If you're not aware of this, the global platform is a small and unfunded little cousin of LTC Covid. It tries to operate in a similar way, although it doesn't operate on the same kind of scale. It's very much focused on low and middle income country settings, and it's not just looking at long-term care, it's looking at a whole range of other issues. And again, if you're interested in participating, that would be wonderful. And I've put up the main web address in the corner of this slide. Okay, I'm going to hand over to our 3 different country teams now, who are going to share some of their preliminary findings. Before that, I really need to acknowledge the very valuable work done by my UEA colleague, University of East Anglia colleague, Fabiana da Cunha-Saggi, who's been supporting these teams and the wider project coordination. So over to the Mexican team, and guys, you've got 8 minutes to talk about Mexico. 8 minutes. I believe Arturo Arcos Soto is going to be presenting on behalf of the Mexican team, which also includes Marisa Vivaldo and Veronica Montes de Oca. And as you can probably tell, I'm just kind of filling while Arturo puts on his microphone. Hola, Arturo.
Yeah, I'm here.
Ah, perfect. Okay, Arturo, you can say to me next when you want me to move slides.
Okay, thank you very much. Thank you for having us. I'm Arturo. I'm representing the team from Mexico in this research project. I'm going to talk to you a little bit about the research that we've been conducting so far. Next, please. Well, some data about COVID and COVID vaccination in Mexico. As you can see, the big purple peak, that's Mexico City. We've had so far the largest number of COVID cases and COVID deaths in the country, which is expected because this is the largest city in the country. We have 9 million people living here, and surrounding us is the second largest peak. That's Estado de Mexico, that surrounds Mexico City in east, north, and west. So so many people move between both states every single day, and that increases the cases, both cases, positive, confirmed, and deaths. But since a few months ago, when we started vaccinating people, we've had a 97% of people who are eligible for vaccination, that's 18 and older, already vaccinated in Mexico, including seniors over 60, who are the second group to get vaccinated here after health personnel. Next, please. This is what we're working on so far. We are conducting virtual and phone interviews with managers and owners of long-term care facilities, and we are gathering data about staff profiles and qualifications, space adjustments, resources and funding, networks, urgent needs, burnout, vaccinations, and government support. And right now, I'll present to you some of the results regarding government support. First of all, the prioritization of the support. First of all, seniors in these facilities have not been prioritized for vaccination. They were given the vaccine at the same time as the other people in their age group. But the only advantage that they had is that they got the vaccinations inside. That meant that they didn't have to go to the vaccination centers that they had all across the country. The national government and through the local governments are the only institution who are giving the vaccination in Mexico. There are no other way to get one. In the case of the personnel, of the staff of the residencies, they had no prioritization either. That means that they had to wait until their age group was vaccinated, go on those days to the centers and get the vaccinations there. But that was many, many months after the seniors got vaccinated. The thing that they got is that the government had testing sites, and they brought those testing sites to the facilities in case they needed them, and they were for free. But the process was a little bit slow, or has been a little bit slow at some moments. And regarding hospital admissions, there has been no priority either, even when worldwide, well, seniors in long-term care facilities have been a very big number of people who end up admitted in hospitals and dying in hospitals for COVID. In the case of material support, there has been no help for personal protection equipment, medications, none whatsoever, according to the interviews. And in the case of groceries and cleaning supplies, the help has been minimum. Only 3 of the 15 interviewed facilities has said that they got some groceries for 2 months, the first 2 months of the pandemic, and then the help simply stopped without giving them any information. In the case of training, there has been some training on COVID-19, and it has been online and non-guided, basically through online self-guided courses and guidelines. And in the case of other kind of training regarding continuous improvement, has been mostly halted in the whole country. And I guess that's the case with this subject in the world. With regulations, there has been some guidelines that involve detection of cases, staff rotation, visits, personal equipment usage, and such things regarding the pandemic. But again, every facility gets the information and they do what they can with that and apply it as best as they can to their needs and to their centers. There has been phone checks from the government only for the first 2 months of the pandemic again, and then they simply stopped. And there has been no visits, like in visits to the facilities from the government to see how they're doing. There has been no pardon of forgiveness of debt and no discounts in taxes or any other cases of debts. There are many challenges that we are facing conducting these interviews. Most long-term care facilities don't want to register to the official CIVISO and HAP databases. Those are the main databases available in Mexico City, and they don't want to be a part of them because there are no benefits and they imply many regulations that they don't want to follow through. Most facilities don't belong to any net support, so they work by themselves and have no other way to get information or resources. And a significant number of facilities operate illegally in Mexico too. That's something that we must consider. Well, in conclusion, long-term care facilities in Mexico have not been a priority for local governments during the pandemic. I mean, it may sound like a bold statement, but every indication points in that direction. Most facilities have only had their own resources to face the pandemic with, lack of resources as they have. That's all they've had so far. And it isn't clear how many of these facilities have closed because of the pandemic, because the databases available are not upgraded in many cases, and that's occurred occurring in that situations. We still don't know how many of them are happening or have happened so far. Thank you very much.
Thank you so much, Arturo. And you could probably see I was rushing you a little bit with the slides, but with 3 presentations in a half-hour session and hopefully time for 1 or 2 questions, we really have to move quite quickly. So now I will invite, I think Gabrielle is going to speak on behalf of the largest South Africa team about what's been going on in the Western Cape. Over to you, Gabby.
Great, thank you, Peter. So yeah, as Peter mentioned, I'm going to talk about some of the work that we've been doing in the Western Cape, primarily qualitative interviews that we've done with long-term care facilities, staff from the Department of Social Development who's responsible for overseeing long-term care, and some what they call mother body organizations that look after groups of long-term care facilities. Just to give you a little bit of background on the South African COVID pandemic and some vaccinations, Western Cape province, where we're based, has had in both the first 2 waves had the biggest outbreaks and less so in the third wave. We've had around 3 million cases and about 90,000 deaths. That is expected. There's been very high levels of underreporting. You can see here total excess deaths are significantly higher, around 273,000, and they expect that the vast majority, about 80% of those, have been older people. And so yeah, the Western Cape was the first province to get kind of major outbreaks and has had to kind of lead the response in South Africa a couple of times. In terms of vaccinations, there has been prioritization of older people in terms of vaccination, and is the most vaccinated population, and there have been efforts to vaccinate older people in long-term care facilities, at least in the Western Cape, where older people were vaccinated on site, but the process got started very late in South Africa relative to the rest of the world. So only around June, July this year did the vaccination start. So that meant that going into even our third wave, a large portion of older people weren't fully vaccinated yet. In terms of the management of long-term care facilities, They're overseen, as I said, by the Department of Social Development. In the Western Cape, we have about 117 of them. For the most part, facilities are registered, and some are funded by the department, although funding is lacking. There's also a relationship with the Department of Health, who's responsible for dementia care. The one conflict that this creates is the norms and standards between both Department of Health and Department of Social Development. Big struggles between these two departments, which has created problems in terms of coordination around the COVID pandemic. Could you go to the next slide, please, Peter? So I'm looking. So then, in terms of the relationship, there was a multi-sectoral task team for collaboration, which then collapsed. Even prior to COVID, the conflicts around who was responsible for what have resulted in big delays of PPE getting to facilities, issues around who should be monitoring facilities in terms of COVID compliance, seeing that a lot of it was IPC compliance that was the main concern, and the Department of Social Development feeling that there was a health issue. Big funding cuts of Department of Social Development in favor of Department of Health that was dealing with the broader pandemic across the country. There were also issues around reporting for vaccination and issues around norms and standards. Although there have been effective relationships at the local office level. In terms of communication, big delays between what was the different lockdown levels and what compliance needed to be put in place for facilities at each level, and creating a lot of frustration for facilities. Eventually, facilities started to develop their own communities of practice and protocols. Towards the end of 2020, the Department of Social Development did develop some standard operating procedures, which were then shared with the National Department of Social Development, who seem to have not done very much over that period. And then there was some training offered for long-term care facilities, and the Department of Social Development gathered a lot of data from facilities and was able to actually get quite a lot of buy-in in terms of reporting. But long-term care facilities that we interviewed felt very uninformed, unsupported in terms of practicalities, training and funding. But then were expected to do a lot of reporting. So they found that very frustrating. In terms of the relationships and coordination between the facilities and those two departments, the Department of Social Development started working from home over the pandemic, didn't make themselves available or accessible to long-term care facilities, which was very frustrating. The one thing that I think the Department of Social Development can be commended for is that they provided support and information to facilities that were unregistered, partially registered and fully registered. So they were actually able to develop some relationships with facilities that previously weren't cooperative in terms of registration, and help them to kind of understand some of the values of registration. Very, very much kind of mixed relationships in terms of the relationships that they had with better resource facilities, being able to more proactively engage with both departments and reporting better relationships. Just in terms of some comments from long-term care facilities, there were a lot of frustrations around expectations of delivery and funding provided. Facilities experienced significantly reduced income because facilities were not able to take on residents. Residents weren't able to pay fees. They already had, very low levels of funding, and then also they had a lot of additional expenses, but more frequent communication between social workers and facilities improved relationships. Under-resourced facilities were unaware of protocols and procedures. They didn't know who to call if there was an outbreak, which created panic and huge amounts of anxieties. And then also long-term care, some facilities were forced to open their doors to the general public for vaccinations days without prior warning. That's all from me. Thank you.
Wow, thank you, Gabby. You managed to cover everything in 7.5 minutes. And I'm sorry for being such a time fascist. But we do have 9 minutes left. So hopefully we now have the Brazilian team who I think Mônica Frank is going to, Mônica Frank is going to present on behalf of the team from the state of Bahia in the northeast of Brazil. Are you there, Mônica?
Okay, I'm here.
Great. Over to you.
Okay. Good morning, good afternoon for all. I'm Dr. Mônica Frank, Director for CREASE. I'd like to thank Peter for the invitation. And I'm here to present what the Intersectoral Committee for Monitoring Long-Term Care Facilities in Bahia, Brazil, has been doing during the pandemic. Next, please. Well, why a committee to monitor LTCF? I'm sure you all know, but someone may ask themselves. Well, in the beginning of the pandemic, especially the existing data, especially those broadcasted in the media, show the concerning rates among the elderly. For example, high lethality rates, especially for the elderly living in facilities in Europe and also in North America. We all know that worldwide, both clinical and social vulnerability are risk factors for institutionalization. These institutionalized ones could be described as invisible citizens for the public policies. So they deserved a different approach from the Brazilian government. That's the equity concept. And since CREASE is a public unit specialized in the elderly care, it was decided that CREASE would coordinate a team to closely monitor this part of the population. As it was not possible to examine each person each day, the chosen methodology was to remotely monitor the facilities through systematic contacts. In other words, monitoring facilities was the best way found to track the number of cases and possible complications on elderly people living there. The objectives, the main objective was not to leave the vulnerable elderly behind. Other objectives were monitor health actions in LTCF and also epidemiological matters in relation to the pandemic. Second, intervene and provide guidance on response to COVID-19 pandemic. And since CREASE does not have the magic power to solve all problems, the third objective was to bring other stakeholders so that the action could be easily capillarized to reach all the municipalities with facilities. This including several health areas and social areas also. Well, the labor process, for the labor process, the interdisciplinary team was divided into 6 smaller teams. One team monitored the LTCL with suspected or confirmed cases. The other 5 teams monitored the facilities without suspected cases. For facilities that presented symptomatic cases, daily phone calls were done. And for facilities that presented only asymptomatic cases, calls were done every other day until January 2021. And after this period, with the start of vaccination every 72 hours. And after the second dose of the vaccine, once a week. The next, okay. The monitoring developments. First, network coordination, articulation with different sectors like health, justice, human rights, and citizens protections in the 3 levels, municipal, state, and federal levels. Second, technical reports. Production of reports, the Commission published 5 bulletins, and the last one, the 6th, is still in press. Testing and results. In most cases, the team leader would arrange key factors for testing and always followed up the results, always. In a special case, team members participated on the collection process at the facilities. For technical meetings in telehealth, remote training on various topics for facility managers and staff, as well as for primary care teams. And 5, internal evaluation meetings to establish and improve work process. Summarizing data shows that 212 facilities were monitored in 85 municipalities, where more than 5,000 elderly people lived on. Of this, 31.03% tested positive for COVID-19. And of this 31.03%, that's 1,632, was confirmed, elderly resident confirmed. Of those 1,632 confirmed elderly residents, 10.72 died. And with the important reduction of the cases, the next please now. Yes, with the important reduction of cases, the committee stopped the monitor and began live and online training actions for all kinds of professionals who care for elderly people in facilities. That's the work we have done, and we, by the end, we are very proud of the good job and the good work for the facilities that we have done. Thank you.
Thank you so much, Mônica. And as you can see, we've tried to squeeze 3 really interesting case studies into the time that normally only 1 case study would be presented. And while I've been showing the screen, I haven't been able to check the chat functions. I don't know if there are any particular questions. I'll stop sharing now. And I don't know if I'm meant to be chairing this session, but I'm happy to do that. So if anybody wants to raise a hand, or if they've got any comments they would like to make in our remaining couple of minutes, that would be great. Yeah, Adelina, please.
I mean, thank you so much. This is so impressive. And I also really want to commend the effort on the putting together the SIAD framework, or SIAD, depending how you pronounce it, and for raising awareness to the Corona Older Network of the issues faced by especially people in care homes in low and middle income countries, and all these issues about the lack of registration, the punitive regimes that may have meant that unregistered care homes were not able to then access the resources that they needed. And thank you so much for illustrating that so well. Also for raising all these, the innovations that we had in South Africa in terms of a bit more coordination between government departments, and and obviously this really impressive mapping of facilities in Bahia and Brazil. So I just wanted to congratulate you. I also wanted to thank Fabiana for putting all these amazing resources on the chat that we will be coming through, and we also hope to capture a lot of your learning and your materials also, if you don't mind us linking to them from the LTC Covid International Living Report. And we're really keen to showcase this really excellent work you have all been doing, and thank you, Peter. So that's not a comment, that's just a question, that's just a comment, but I really appreciating what you have done here.
Well, thank you so much, Adelina, and just thank you so much, presenters. You did brilliantly in very short periods of time. So great. But as you can see, we've got about 200 presentations over these 2 days. So, but thank you so much, Adeline. It was fantastic that you gave us this platform.
I mean, if there's 1 or 2 more questions, just quickly. We do need a break, most of us. But does anybody with a burning question for the speakers? Any quick reactions? Or to each other?
I mean, I'm happy to say that clearly what we're starting to do here is we've done about 2/3 of the data collection. And you can see already that there are real differences between what's happened at those local levels. And one clear example is that in, for example, Mexico City, I think just guidance and protocols from any official agency were not available until, I think, May or June. In South Africa, again, you saw a tremendous delay, and at the national level, they didn't become available till even later than that. Whereas in the state of Bahia in Brazil, because this group was able to take a more coordinated response, and also because of other things that were going on in Brazil, again, a spontaneous network nationally, guidance and protocols were provided much more quickly, and were also much more tailored to the context of settings which are more resource poor.
Thank you. So I think everybody may be a bit tired as well, because we've been going for a few hours, and I think a break is important also for mobility, health, and all that. Yes, we hope to also continue this also relationship with the Corona Older Network, and also some of the wider issues that you're raising through that as well, because it's not just about care. So let's now have a break. We have another session starting at 15 past the hour. We're going to be hearing about care home visits and its impact. And I see some of the speakers have also already joined us. So just give us a minute. We're going to stretch our legs and do everything one needs to do. And we'll see you shortly. See you very soon. Thank you all.